Welcome everyone to the September 2023 Rehabilitation and Movement Sciences Grand Rounds. Today we have Dr. Stephen Kareha. He is going to talk to us about unleashing the power of movement, understanding expert physical therapist practice. Dr. Kareha graduated from Gettysburg College with a bachelor's degree in health and exercise sciences with an emphasis in athletic training. He received a Doctor of Physical Therapy degree from Arcadia University and then completed his postgraduate training at Allied Services in Scranton with an emphasis on back and neck injuries and vertigo. He then earned a PhD in physical therapy at Nova Southeastern University and is board certified in orthopedic physical therapy. He is director of orthopedic physical therapy residency and director of spine physical therapy fellowship for St. Luke's University Health Network in Bethlehem and assistant professor, clinical associate in the Department of Physical Therapy at DeSales University. His research interests include diagnostic classification for the shoulder complex, physical therapists in primary musculoskeletal care, psychologically informed care, and health services research. Dr. Kareha practices orthopedic physical therapy at St. Luke's University Health Network. He teaches evidence-based practice and musculoskeletal content in the entry-level Doctor of Physical Therapy program at DeSales University and teaches evidence-based practice and evaluation and management courses in the St. Luke's University Health Network Orthopedic Residency and Spine Fellowship. Dr. Kareha currently serves as an editorial board member for the International Journal of Academic Medicine and as a reviewer for multiple journals. Without further ado, I will turn it over to Dr. Kareha.
The only thing you forgot there was that I also wear awesome bow ties, so thank you. So today we're going to talk about unleashing the power of movement, understanding expert physical therapist practice. This is our statement of need, and this is for all providers. This is our designation statement, and I have nothing to disclose. By the end of today, I want you to better understand the four elements of the movement system, the major considerations that physical therapists use for diagnostic decision-making, and the components of expert physical therapist patient management. So let's start with a little word association. When I say physical therapy, what do you think of? Well, unless you are a physical therapist or have been under the care of an expert physical therapist, most often pain and torture comes to mind. Or perhaps personal training or powerlifting, or passive modalities such as laser, ultrasound, heat, or even massage. Not only is this not an accurate picture of what a physical therapist does, if only passive interventions are performed, it's a sign of poor care. Furthermore, there have been many studies over the years with conclusions that physical therapy works or doesn't work. The problem with these studies is that physical therapy in these studies is ill-defined and inconsistently defined between the different studies. In fact, physical therapists are not technicians, and the care they provide is tailored to the individual. Just like physicians tailor their interventions to their patients, physical therapists consider the patient as a whole, differentially diagnosing the cause of the chief concern and using that diagnosis to determine the best interventions or referral to other providers as appropriate. Many providers are surprised to learn how many considerations expert physical therapists run through during each and every patient encounter. Furthermore, physical therapy is a broad field where physical therapists can specialize in 9 different specialties, such as cardiovascular and pulmonary, clinical electrophysiology, geriatrics, neurology, oncology, orthopedics, pediatrics, sports, women's health, and wound management. So now that we know that, let's delve into what defines all of physical therapist practice. Movement. Movement is essential for the interaction of the individual with their environment. It provides meaning and quality to life. It involves so many things that it has been hard to describe. Hence all this confusion of what a physical therapist really does. It wasn't until about a decade ago that some researchers put together a clearer picture of the movement system as not just the musculoskeletal and nervous systems, but all the body systems that integrate to comprise human movement. The problem with this is that it still didn't answer what a physical therapist actually investigates during their consult exam and subsequent intervention. So a few years ago, a group of experts published an updated definition of the movement system, more accurately using the elements that are required for human movement. After considerable investigation, it was found that 4 major elements comprise human movement. They are mobility, motor control, force, and energy. These 4 elements also better define what it is that physical therapists bring to the proverbial healthcare table, since physical therapists are the experts of the movement system. So let's dive into those elements a little bit more in depth. Mobility can be defined generally as the passive movement of different body tissues. That could be I must have hit the button. My apologies. Apparently I was on mute. So I'm not sure where I was when, so I will go back to here. So I just want to just redefine the movement system, the mobility and motor control, force, and energy for you. I apologize if I went on mute before that, but here we are. So mobility can be defined generally as the passive movement of different body tissues. This can be physiologic mobility or movements we naturally think of happening during active movement. So osteokinematics. These are the things that happen in the normal planes of the body, transverse, sagittal, coronal, or combination thereof. And they're usually the ones people think of when they think of mobility. The other aspect of mobility is accessory mobility. And these are the movements that do happen normally, but they're not usually appreciated or understood by most people. So for joint motions, this is arthrokinematics, or the slide, glide, and roll, the things that are happening behind the scenes. However, the element of mobility also includes important things like integumentary tissue mobility or scar mobility, neural mobility or neurodynamics, and muscular extensibility. The next element is motor control. Motor control can be determined by analyzing the feed forward or feedback mechanism of many types of activities, including static balance, dynamic balance, vestibular integration, sensory integration, motor coordination during movement, resulting in changes in pain or the amount of available movement during activity. And these are examples of upper extremity and lower extremity motor coordination tasks. The next element is force. Force is comprised of things like muscle strength, which can be tested and improved manually or with mechanical resistance. Force is also comprised of power, which is how much force can be generated over a short amount of time. Power can be assessed and addressed with things like plyometrics, acceleration testing, or speed testing. And the last element is energy, and this can be confusing because generally you think of endurance like swimming or walking or doing things for prolonged periods of time. And yes, endurance is a component of energy, but it is more than just endurance. It includes those aspects of human movement that make endurance possible. Energy also incorporates cardiovascular and pulmonary function, including how the pulmonary system does not function well in patients with diseases like cystic fibrosis, and how the airways respond to different activities. It's also how the vascular system and the lymphatic system responds to different conditions. So things like lymphedema and venous or arterial insufficiencies. Now that we know there's four elements to the movement system. And the movement system is the aspect that physical therapists provide the most value to the healthcare system. Great. However, this is not the only consideration that's utilized in diagnostic decision-making by expert physical therapists. So let's take a look at this from a wider perspective. What is a physical therapist's job? Well, the first is to find out the patient's needs. So, diagnosis. And how to meet those needs, or prognosis and management. And to be useful, a diagnosis should inform the prognosis and management. So terms like low back pain doesn't really help because it's a symptom and it does not inform prognosis and management. Researchers have found that in order for a diagnosis to appropriately direct prognosis and management, the diagnosis must answer 7 questions. What is wrong? Who is the best provider to complete care and resolve the problem? What is the prognosis? So how long will it take to get better? What are the safety precautions that are necessary to help the problem resolve? What are the best options for overarching intervention strategies? And within each of those intervention strategies, what are the specific interventions that are necessary? And what are the appropriate dosages of those interventions? To address some of these issues, the ICF model has been proposed as something to help integrate all that information. So it's not just looking at pathology, but also looking at body structures and functions, activities, participation, environmental factors, and personal factors. This is fantastic and has been taught in medical schools and physical therapy schools for years. But I don't know about you, most people leave school from whether it's medical school or physical therapy school and is rarely used or even considered in practice. But going back to it, it does help to show the integration of a lot of different components for how people function. There's a couple problems with this though. It's arduous. And where do you put the movement system? Well, most likely, you're going to put it into the body structures and functions category. because that's probably the area where it fits the most. Another issue is what is taught and described very frequently. Environmental and personal factors are glossed over, forgotten, or most likely minimally integrated with the issue. Lastly, many providers just simply look at the pathology. And partially, this isn't necessarily the provider's fault because it tends to be payer driven, as we need to use ICD-10 codes, which are largely pathology based, to get paid for our services. So pathology tends to be where the majority of the focus is, and it's assumed to result in a useful management plan. The problem with this approach is that while research has shown it is useful to focus on pathology for surgical decision-making, research, as well as seeing the massively rising costs of healthcare in the United States and the rest of the world, has shown time and time again that a singular focus on pathology does not work well for non-surgical decision-making. Now, you might be saying, oh my gosh, the next thing you're going to tell me is the movement system is going to fix all of those problems. And I would argue this is not the case either. Expert physical therapists don't singularly focus on the movement system either, because while it does provide many of the answers, it doesn't provide all of the answers. Instead, expert physical therapists have 4 major considerations in their diagnostic decision-making to answer those 7 questions. The first considerations are the environmental and personal factors, because environmental and personal factors are what the patient brings to the table. It's the platform that colors and forms the foundation for everything else the provider needs to understand the patient's presentation, perspective, and needs, so the provider can best help the patient by answering those 7 questions. So on top of the foundation of these environmental and personal factors, an expert physical therapist looks at the movement system, and this will help inform the specific interventions that are needed. The movement system data also partially informs who the best providers would be to resolve the problem, as well as partially informs the best overall intervention strategy options. As mentioned, pathology is very important for determining the safety precautions, so what to avoid doing. It also complements the information gleaned from the movement system exam to determine who is the best provider or providers to resolve the episode of care, and also partially informs the prognosis for how long it will take the problem to resolve. The fourth consideration of an expert physical therapist is pain phenotype. This is one aspect that is completely omitted by the ICF, but it does provide significant information necessary for accurate non-surgical decision-making. We'll explore this more shortly, but for now, please note that there is significant literature on pain phenotype that shows it significantly directs the appropriate dosage of interventions, and in combination with the information gleaned from pathology, the pain phenotype directs the prognosis. Lastly, in combination with the information gleaned from the movement system, the pain phenotype directs the overarching intervention strategy options. Now, as I've been working with many expert physical therapists and many other expert providers and researchers outside of the orthopedic and musculoskeletal care realm, there are other symptoms such as dizziness and other neurologic symptoms that seem to have the same phenotypes as pain. Those researchers in persistent dizziness have dubbed this category dysfunctional neuroplasticity. Thus, since the diagnosis of pain phenotype and dysfunctional neuroplasticity phenotype have similar implications in the intervention type and prognosis, it's possible to not have any pain or dysfunctional neuroplasticity that coincides with pathology and movement, I recommend that we consider this category functional neuroplasticity. And we'll come back to this later. Now, let's discuss each of these major considerations that expert physical therapists use to diagnose and manage patients. Let's first start with the environmental and personal factors. Environmental factors are looking at the cultural and social aspects of a patient's life. Personal factors are looking at the patient's beliefs and psychological factors. These aspects comprise the patient perspective. They are what they bring to it is what they bring to the table. And these provide the context to which everything else that is assessed matters. So how do you get this information in the first place? Well, yeah, you can ask. And that's great and appropriate. And there are three major components that can help providers get this information more effectively and efficiently. They comprise the fears and concerns that a patient has, the expectations that they bring to the table, and the comparable sign that is meaningful to the patient. So first, as I've been working with expert providers in many different specialties, one of the best ways that I've learned to ask this is, what is the greatest concern about your problem? And let's be real. If a patient's biggest concern was simply the pain or the dizziness, there's no way they would see a medical provider. Over-the-counter medication is so much cheaper, easier, and simpler than getting in your car, going to see a medical provider, scheduling an appointment, etc. It's got to be something more than that. Maybe it's because they want to avoid getting addicted to pain medication, or because they're concerned about becoming a burden on others, or that this pain, dizziness problem is going to become permanent or will worsen or won't resolve without help. So now that we understand their fears and concerns a little bit better, now we need to understand their expectations. This seems simple. You just ask, right? Well, asking is excellent and definitely the first step. I always recommend that providers ask. However, the Johari window is a great depiction of the information that you'll get when interviewing a patient, and it was developed back in 1955, so a while ago. For those of you who are not familiar with the Johari window, it's a model that helps people understand their relationships with themselves and with others. And in this case, it helps us get a better idea of explicit and hidden expectations. The first box, the open self, is what you get when you just ask what's going on. You're going to get a lot of great information, and that's very good. The next box is the blind self. This is the information that the patient didn't know, but you learned it from observation or asking diagnostic questions or performing diagnostic testing. Even novice clinicians are able to ask the right questions to draw out this information, to gather appropriate information, to find out more about the blind self. These are what we're trained to do in medical school or physical therapy school. The challenge and the area that expert providers shine is at getting to the hidden self. This is the stuff that the patient knows but is not likely to share. And sometimes expert providers are even able to get through to the unknown self. This is the last section where the patient didn't even know this about themselves or realize that these things were true. These are the sections where the patient's hidden expectations lie. And the problem with that are hidden expectations are the things that cause most issues in relationships, including the therapeutic relationship between the provider and patient. So these are things like the patient after a total knee replacement. And they come to you and say, you know what, all I want to do is get out of a chair. So if you're familiar with the course of care of total knee replacements, about a month later, you're thinking, oh my gosh, they're doing so much better. And you ask them how they're doing, and they respond, I don't understand. The surgery failed. I'm no better. And you look completely bewildered at the patient because you're thinking, you're back to doing everything you want to do. And they respond to you, yeah, but I can't run 5 miles like I used to. And you're completely blown away by this because they never told the surgeon or the physical therapist that they really wanted to return to running. So it was never addressed preoperatively as an expectation or postoperatively either. These are the things that expert physical therapists are well equipped to find out. One of the questions that I asked to help with getting at this is, if I can magically fix you overnight, how would you test it tomorrow morning to prove that it's really fixed and to prove that I'm not just swindling you? Other things for more chronic issues would be, what do you think is going on? I mean, let's be real, they have Google, they have a lot of time to investigate the problem going on, and they get lots of information, albeit probably not accurate, but they get a lot of information. Trying to understand what the patient knows about the problem and trying to understand what they believe about their problem is imperative. And part and parcel with this is, what do you think, asking the patient, what do you think will fix the problem? Or what have you already tried? Or what do you feel won't work? And the last part of understanding the patient perspective is the comparable sign. Now, you may have been trained to call this an asterisk sign or functional movement task or concordant sign or test-retest outcomes or baseline or observable task. And quite honestly, all of these refer to the same thing. And no matter what, it needs to be something that you can consistently compare from one point to another. And it needs to be something that matters to the patient. When I say consistently compared from time to time, it needs to be something that you can look at and determine, how is the control or symptoms or speed or volume or symmetry compared to normal human movement, or at least functional movement. It needs to be meaningful to the patient, because without the meaningfulness, it's completely useless. I know a lot of physical therapists or surgeons or physicians will say, you need to improve by a range of motion of 5 degrees in a specified amount of weeks. But not a single patient that I've ever worked with has ever come in saying, you know what, my goal is to improve shoulder range of motion by 5 degrees. It's completely ridiculous. They want to be able to reach to a top shelf and put something away, or scratch their head, or brush their hair, or put on their pants or their shirt. These are the things that people care about. And those are the things that you should ask about and make sure that it's mutually understood that you're heading in the same direction. Because if you don't know where you're going, every road will get you absolutely nowhere. So now that we have a better understanding on patient perspective, those environmental and personal factors, we can further ask questions to do a good physical exam to complete the diagnosis and answer those 7 questions of what is wrong, who is the best or who are the best providers to resolve the problem, what is the prognosis, so how long is it going to take to get there, what safety precautions do you need to follow to avoid re-injury or re-aggravation or prolonging the prognosis? What are the intervention strategy options that are appropriate for this problem? And then within those, the specific interventions and appropriate dosage of those interventions to get patient satisfaction and understanding. Now, some providers may look at this and completely bristle, saying patient satisfaction is not everything. Okay, I can appreciate that, because you don't want to lie and tell someone just what they want to hear to make them satisfied. However, most humans appreciate honesty. And if you can answer those questions in a way that is honest and accurate to the best of your ability, patients will appreciate that. They might not like it, but they will appreciate it and be satisfied that you gave them a full response to those 7 questions. Expert physical therapists do this by building upon the environmental and personal factors, by considering the movement system, pathology, and functional neuroplasticity. So the movement system, as I mentioned earlier, requires mobility, motor control, force, and energy. Those four elements are examined and evaluated to help inform what is wrong, as well as who is the best or who are the best providers to complete the care. What are the best overarching intervention strategies for this patient, and what specific interventions are necessary to help this patient? Then looking at pathology and a review of systems, looking at all 11 body systems that are in all anatomy and physiology textbooks. These will inform the safety precautions that must be considered so that we can resolve the problem most efficiently. Pathology also helps inform what is wrong and helps inform who the best providers are to complete the care. It also helps inform prognosis, so how long it's going to take to resolve. And finally, functional neuroplasticity. As I mentioned earlier, for every patient, there is a possibility there is no dysfunctional neuroplasticity, but there may be pathology and a movement system problem. I also want to add that for other patients, there may be no pathology, but there may be some dysfunctional neuroplasticity and a movement system problem. And there are also cases where there's no movement system problem, but there is pathology and dysfunctional neuroplasticity. So, this category of functional neuroplasticity helps inform prognosis, the overarching intervention strategy, and the appropriate dosage of interventions. Since this concept is relatively new for most people, I'm going to go into this a little bit more in depth. As you can see from the slide, there are three major phenotypes of dysfunctional neuroplasticity: nociceptive, neuropathic, and nociplastic. Also, please note that most patients will have at least a small component of each of these types of functional neuroplasticity. So it's most important to determine the predominant phenotype and then treat accordingly. First is nociceptive pain or dizziness. They're effectively tissue issues. These are things we normally think of as medical problems. These are things that when you sprain your ankle or have BPPV, or there's an issue in the tissues that is causing a nociceptive signal to be sent to the spinal cord. It's then relayed to the brain. Or in the case of BPPV, to be fair, it goes directly to the brainstem. The brain then sees it as a threat to the system. The brain then sends a signal to the spinal cord and then to the tissues to respond. Now, the good thing is about 55 of outpatients are nociceptive dominant. That's great. But how do you differentiate patients that are nociceptive dominant? Well, researchers have found that if you have proportionate pain or symptoms, and they have very clear aggravating factors and clear alleviating factors, and they may have intermittent sharp, dull, aching, or throbbing pain at rest, but they don't have any night pain, dysesthesia, burning, shooting, or electric pain. If they have all four of these pieces, there is a 100-to-1 odds that the patient is nociceptive dominant. So once we differentiate this component, what do we do? Well, we look at the severity, tissue irritability, nature, stage, and stability, or SINS. We can then determine those components that we talked about that functional neuroplasticity informs. So looking at tissue irritability informs the appropriate dosage of interventions by better understanding the worst symptoms that you're getting, the symptoms that are there at rest, how easy those symptoms are to aggravate, the ability to move, and disability. The next is nature. For nociceptive problems, we focus on tissue healing times, or how long it takes the tissues to heal. And this helps inform prognosis. And the last two components are stage and stability. And these help us look at the overall intervention strategy, which for somebody with nociceptive dominant symptoms, it's very tissue specific. The next phenotype is neuropathic. 25% of outpatients are peripherally neuropathic dominant. These are patients where the nerve itself is irritated, like vestibular neuritis, or lumbar radiculitis, or thoracic outlet syndrome. These are things where the nerve itself is irritated. So a signal is sent from the nerve to the spinal cord and then relayed to the brain. The brain determines if there is a threat to the system, and if so, it then sends a signal to the spinal cord and then to the tissues that the nerve innervates, because the brain is perceiving the problem is from the distal aspect of those axons. So how do you determine if somebody is neuropathic dominant? Well, researchers have found that if symptoms are in a dermatomal or cutaneous distribution, if they have positive mechanical testing, whether neurodynamic, positional, palpation, and they have a history of nerve pathology or compromise, there's a 150 to 1 odds they are neuropathic dominant. We use the SINS acronym again for this category, but it changes slightly. We still look at severity and neurodynamic irritability, looking at the worst symptoms, symptoms at rest, ease of aggravation, ability to move, and disability to determine the appropriate dosage of interventions we're going to apply. Next, we look at the nature of the injury. In other words, the grade of injury. This will help inform prognosis. And then again, looking at stage and stability to fully understand the overall intervention strategies that are necessary to resolve this problem. And somebody with neuropathic dominant symptoms needs neurodynamic interventions. So your nerves like 3 major things. They like space, they like movement, and they like blood. They also like, and if you take any of those 3 things away, they get very, very angry very fast. And the intervention strategy for this phenotype includes things like restoring space for the nerve to move, movement of the nerve, and blood flow to the nerves. And it's beyond this talk to talk about the specifics of these, but I'd be happy to discuss those with you at another time. The last phenotype is nociplastic symptoms, and these are about 20% of your outpatients. This phenotype, researchers have found, is presumably a persistent neuronal dysregulation of the central nervous system, causing an efferent response that is sent from the brain to the spinal cord to the tissues without any significant afferent input to the system. So these are patients that you can diagnose because their pain, dizziness, or symptoms are disproportionate to the physical examination. Their aggravating factors and alleviating factors are also disproportionate. These are patients that everything aggravates the symptoms and nothing eases them. They have diffuse palpation tenderness. They also typically have psychosocial issues. When researchers have found that a patient has all 4 of these categories or components, it's a 486 to 1 odds that they're nociplastic dominant. All right, so how do we determine what to do with these patients? In this case, severity, symptom irritability, nature, stage, and stability are all centrally mediated. So effectively, prognosis is absolutely going to be extended. The overarching intervention strategies, which most likely are going to be multidisciplinary in the appropriate dosage of interventions, is going to most likely be graded. When we're looking at patients with nociplastic dominant symptoms, you're going to need to think of big multidisciplinary picture. They're going to need some form of cognitive intervention, such as pain neuroscience education, cognitive behavioral therapy, or acceptance and commitment therapy, some form of movement intervention, some form of sleep intervention, and some form of goal intervention. And these things can be interventions that are very simple or complex, depending on what the patient needs. An example of this would be sleep. It could be as simple as helping the patient better understand good sleep hygiene and coming up with a plan to implement better sleep hygiene. Or it could be as complex as a sleep medicine consult with testing and intervention. And remember, as I mentioned before, functional neuroplasticity very frequently has components of each phenotype. So you're looking at phenotype dominance. So I just want to reiterate, you may have one patient that is nociceptive dominant and has small components of nociplastic and neuropathic symptoms, whereas you might see another patient that is predominantly neuropathic, but does have some significant amount of nociceptive symptoms, as well as a little bit of nociplastic response. And then on a third patient, they may be predominantly nociplastic and have some neuropathic symptoms as well. So putting all of these together, you have the movement system, pathology, functional neuroplasticity on a foundation of environmental and personal factors. And the challenge and skill of the expert physical therapist is to integrate all of these four major considerations to provide the answers to the patient's 7 questions, which are: what is wrong? Who is the best provider or providers to help resolve this problem? How long is it going to take, or prognosis? What do I need to watch out for? So safety precautions. What is the appropriate intervention or overall intervention strategy? And then within that, what are the specific interventions necessary? And what is the dosage of interventions that are necessary to resolve the problem? So now that we understand more about the specific considerations that expert physical therapists use to diagnose patients, how does it actually work in practice? This is the cycle of physical therapist practice that a group of experts put together. And I want to highlight that this cycle is completed at least once every patient encounter. But depending on the patient's needs, it may be done many, many times in a single encounter. It all starts with a better understanding of that patient perspective. Building off of that patient's perspective, gathering history and physical examination data and information to determine a diagnosis that is comprised of those 4 major considerations of functional neuroplasticity, movement system, pathology on a foundation of environmental and personal factors to determine the answers to those 7 questions of what's wrong, who is the best provider to help resolve the problem, prognosis, safety precautions, overarching intervention strategies, specific interventions, and appropriate dosage of interventions. Once we figure out the treatment options and who is the best to manage the patient, we reassess that same comparable sign. Please note that if further diagnostic work is needed, you may not be able to reassess it now, but an expert physical therapist sets the stage for it to be retested as soon as appropriate. And then it all comes back to understanding the patient's updated perspective. So now that we talked about the cycle a little bit better, let's put that into a patient case. We have a 74-year-old female with pain radiating down her leg that began 2 weeks ago insidiously. All right. What are the environmental and personal factors? She lives with her husband, and prior to this incident, she regularly cares for her grandchildren, but now is unable to lift them or bend to do her yard work. What are her fears and concerns? Well, she's worried about not knowing what's going wrong. She's really concerned that it's not improving over the past 2 weeks, and she wants to avoid painkillers and surgery. And she's really afraid of becoming a burden on her family because she's going to Italy in 2 weeks, and she needs to sit on a plane for 10 hours. And when she gets there, she wants to be able to walk and not hold her family back. She also wants to return to being an active grandmother. So these comparable signs that are very meaningful to the patient are sitting, walking, gardening, and caring for her grandchildren. So now let's better understand now that we better understand the problem in the patient's eyes, we take a good history and perform a thorough physical exam. There's a lot on this slide, so let me summarize. Her past medical history and surgical history includes hyponatremia, pancreatitis, hypertension, and congestive heart failure due to that pancreatitis. Also, she did have a cyst gastrotomy 10 months ago for the pancreatitis, and she subsequently developed a pancreatic pseudocyst that has been causing increased fluid collection in her abdominal cavity. And she does have a possible infection, or she did have a possible infection, for which she's been treated with a stent, and the plan is to remove that stent 4 weeks from now. She's been steadily improving from this back pain, from this cyst gastrotomy, but is still seen under the close watch of her gastroenterologist until the completion of care, hopefully 4 weeks from now. She was a former smoker, but she quit about 40 years ago, which is awesome. And other than the cyst gastrotomy, her only surgical history was some dental surgeries with no complications many years ago. Her current medications are mostly due to the focus on the pancreatitis and the cyst gastrotomy. She's on Percocet, Toprol, and Zofran, and she's also taking a multivitamin for general health. Her allergies are to bee stings, hydromorphone, and tetanus vaccine. Her systems review is relatively unremarkable, as you can see, except for GI, musculoskeletal, and neurologic systems, which we need to investigate further. So looking back at her history a little bit more, she has pain in her back and her right posterior leg down to her posterior calf. It's severe, and she's burning in her leg when sitting and not as much with standing, but she does with walking as well. So it's position and movement dependent. Time of day doesn't really change symptoms, but it is worse with sitting and prolonged walking as well. Besides the sitting and prolonged walking, bending also bothers it, and it's alleviated by lying down. And also, from a gastro standpoint, there are no changes with or after eating. She also has very good support at home. And while she does have some anxiety, she did have a very good experience with resolving shoulder pain conservatively 10 years ago. So that's a huge positive. There's a lot of physical exam findings for this patient, so I'm only going to focus on the important ones for this case. Within the mobility element, her trunk was shifted to the left in static standing. She has a moderate restriction into trunk flexion, and the more she did it, the more symptoms peripheralized. And if you're not familiar with the term peripheralization, very simply, it's the process of symptoms moving more distally, and centralization is the opposite of that when symptoms move more proximally. She has a major restriction into trunk extension that peripheralizes symptoms with repetition. She also has an inability to correct that lateral shift when she's at rest. But when assisted, her symptoms start to centralize somewhat with repeated attempts. She's also quite hypomobile from L3 to L5, and she does have a positive straight leg raise and slump test on the right, demonstrating abnormal neurodynamics. Her remaining lower extremity mobility tests were pretty unremarkable. In addition to her mobility aspects in from a motor control standpoint. When you correct her posture in sitting, it partially centralizes the symptoms to her mid-thigh. But pain significantly limits her ability to transfer and ambulate because she has pain when weight bearing on that right side. She has normal dermatomes and deep tendon reflexes, and her force is a little bit weaker, but it's equal bilaterally and within functional limits for her age and activity level. Her blood pressure, heart rate, respiratory rate, and oxygen saturation were within normal limits. And she's unable to walk any significant distances due to pain. So we didn't directly physically test endurance, but implied it because she couldn't walk for longer distances. So you can absolutely argue that's not a true test of endurance, which it isn't, but there was no need to aggravate symptoms worse. So with this information that we gleaned, what is the diagnosis? Well, neuropathic pain phenotype is the functional neuroplasticity. Lumbar, lateral, and extension hypomobility is the primary movement system problem. And L5 radiculopathy is the pathology. So let's answer those 7 questions now. What's wrong? There's a lumbar, lateral, and extension hypomobility with neuropathic L5 radiculitis. Who is the best provider or providers to complete the care for this issue? Well, a physical therapist, a PCP, and potentially pain management if necessary. And as a side note, she needs to continue seeing her gastroenterologist for her GI problems, but they don't appear to be a factor in this back problem. This specific problem should take about 6 weeks to resolve, which, if you notice or recall from her concerns before, may become a problem because she's planning on leaving for Italy in 2 weeks. I would expect that in about 1 week to be able to correct that shift and to centralize symptoms by the end of the 2nd week. By the end of that 2nd week, she should be able to walk well, and which will make walking in Italy better, but sitting will likely need to be adapted to significantly avoid aggravating symptoms. And then about 4 additional weeks to fully resolve those motor control deficits that we found, to be able to sit for long periods of time and return to fully caring for her grandchildren without concerns of re-aggravating her back. There are no red flags indicating the need for further diagnostic testing or imaging, but sitting and bending will peripheralize symptoms, so we want to avoid doing those as much as possible and early on to help provide better context and better situation for her symptoms to resolve. We need to treat this by focusing on neuropathic interventions to improve space, movement, and blood. She has high tissue irritability, so there's going to be a number of palliative aspects that are going to be necessary. Specifically looking at correcting the mobility in combination and coordination with oral anti-inflammatories to decrease the irritation of the tissues. And then, once we do that, then working on those motor control retraining to restore the movement system. And based upon that overarching treatment strategy that's necessary, you're going to need some palliative medications and heat, as well as very frequent movements to centralize the symptoms, at least at first. So that forms the treatment options, and we're looking to co-manage this, as mentioned before. And reassessing the patient based upon those comparable signs of sitting, walking, gardening, and caring for her grandchildren, and looking at how the interventions changed the control, the amount, the speed, the symmetry, and symptoms in each one of those will help determine where we are so that we can then reassess that patient's perspective. So in summary, today we talked about the 4 elements of the movement system: mobility, motor control, force, and energy, and how the movement system integrates into the 4 aspects of the physical therapist diagnostic model, looking at environmental and personal factors as the foundation, and the movement system, pathology, and functional neuroplasticity built upon that foundation. And implementing that diagnostic model into expert physical therapist practice, starting with patient perspective, gathering history and physical exam, diagnosing, managing the patient appropriately, and then reassessing. So these are the references used for this presentation. And I specifically want to thank Dr. Bays for all his specific input into the development of this project, and all of our wonderful residency and fellowship faculty that have also provided input to make this project better. And thank you for listening. So what questions do you have? Feel free to unmute yourself or type into the chat.
With this model, what is your physical therapy practice standpoint? Where do you see it going in 2 to 5 years if you had your druthers?
That's a very good question. So the question was, where do I envision this going? One of the issues with physical therapy, and because of time, I cut this out, there is so many different factions and different terminologies people use. There are so many guru-based camps that have different perspectives. And really, we are looking at the same problem in slightly different ways. And this model integrates all of those, at least the evidence-based aspects of each of those. And it's looking to find common terminology and a common language to better understand what is going on and how to inform prognosis and management, and better communicate with other professions using similar terminology that they've at least heard of. There are a number of guru camps that use terminology that no medical provider, including physical therapists, could ever figure out unless they were very specifically trained in that little corner of the world. So my ultimate hope is that we can publish this and start implementing it in PT schools, residencies, fellowships, and throughout all of physical therapist practice. All right. So if there are no other questions, I thank you for listening, and please contact me if you have any questions, concerns, or feedback, especially if it's feedback about how to make some of this information clearer and more concise. Thank you.